Assalamu alaikum. Now I would like to discuss about adrenal gland pathology or disorders of adrenal gland. This is the USML Inner Circle PDF where I will discuss, and I will put in my input also, and start with my intro where you will hear a murmur. Can you tell me the name of this murmur? Okay, now adrenal excess. Okay, in adrenal excess, functional adrenal excess, there may be cortisol producing adenoma, there may be adrenal producing adenoma. So, in functional adrenal excess, you should remember the cap. What does the cap mean? Cortisol producing adenoma, which is most common, aldosterone producing adenoma, and pheochromocytoma. These are the functional adrenal masses. Cortisol producing adenoma. Cortisol producing adenoma usually causes central obesity, moon phase, and enlarged dorsocervical fat, hypertension, proximal muscle weakness, hyperglycemia, and hypokalemia. In cortisol producing adenoma, there is elevated cortisol. So, as in adenoma, there is continuous production of the cortisol and decrease ACTH and decrease dihydro dehydroepiandrosterone sulfate, decrease ACTH, decrease dehydroepiandrosterone sulfate, and no suppression by dexamethasone. It is not suppressed by dexamethasone. In aldosterone producing adenoma, where you will get hypertension and hypokalemia, there is elevated plasma aldosterone to plasma renin ratio. Plasma aldo to plasma renin ratio. Plasma aldosterone to plasma renin ratio is more in aldosterone producing adenoma. In pheochromocytoma, there is paroxysmal tachycardia, headache, tremor, and hypertension. There is elevated urine metanephrine and catecholamine, and elevated plasma metanephrine. Okay, now Conn's syndrome, primary hyperaldosteronism or Conn syndrome. Primary hyperaldosteronism or Conn syndrome in primary hyperaldosteronism or Conn syndrome, there may be bilateral adrenal hyperplasia. There may be bilateral adrenal hyperplasia 60%, or there may be unilateral adenoma. Bilateral adrenal hyperplasia 60% or unilateral adenoma, difficult to control hypertension. In primary hyperaldosteronism Conn syndrome, there may be hypokalemia and metabolic alkalosis. There may be hypokalemia and metabolic alkalosis, and no extravascular volume overload, aldosterone skip. No extravascular volume overload, aldosterone skip. In primary hyperaldosteronism, there may be elevated plasma elevated plasma aldo, low renin, and aldo to renin ratio, aldo to renin ratio is mm, aldo to renin ratio elevated more than 20, and absence of aldosterone suppression with oral saline load. An abscess of these two are very high yield talk, like elevated aldo, low renin, and aldo renin ratio is higher, more than 20, and there is absence of aldo. If we do saline load test, saline, then there is absence of aldo. CT scan of the adrenal gland to determine uh, bilateral adrenal hyperplasia versus adenoma. Treatment for bilateral adrenal hyperplasia is MRA, mineralocorticoid aldosterone, MRA, mineralocorticoid receptor antagonist, spironolactone. And for unilateral adenoma, there is surgical resection is preserved. In some patients, the characteristic electrolyte abnormalities are apparent only after thiazide diuretics is initiated for blood pressure management. So if somebody comes with hypertension with hypokalemia, measure plasma renin and plasma aldo concentration, If plasma renin and aldo is high, if both are high, it is secondary hyperaldosteronism. If plasma renin is high, aldo is high, plasma aldosterone concentration by renin plasma aldosterone concentration by plasma renin ratio is near about 10%, and in this secondary hyperaldosteronism. In secondary hyperaldosteronism, in secondary hyperaldosteronism, what are the cause? Diuretic is one of the cause. Renovascular hypertension, cirrhosis, CCF, cirrhosis, malignant hypertension, renal secreting tumor, coarctation of the aorta, and malignant hyperthyroidism. So for secondary hyperaldosteronism, these are the cause, like malignant hypertension, renovascular hypertension. There are two hypertension, then cirrhosis, CCF, renovascular hypertension, malignant hypertension, cirrhosis, nephrotic syndrome, coarctation, and the diuretic. In for primary hyperaldosteronism to happen, plasma aldo would be high and plasma renin would be low, and plasma aldo to renin concentration would be more than 20, and plasma aldosterone concentration should be more than 15. This is plasma primary hyperaldosteronism. Adrenal computed CT tomography to determine the pathology. Adrenal uh, computed CT tomography to determine the etiology. If both are low, renin is low, aldo is low, it may be other causes of hypertension and hypokalemia. Other causes of hypertension and hypokalemia: congenital adrenal hyperplasia, glucocorticoid resistance, exogenous mineralocorticoid, Cushing syndrome, and altered aldosterone metabolism. Congenital adrenal hyperplasia, glucocorticoid resistance, exogenous mineralocorticoid, Cushing syndrome, and altered aldosterone metabolism. What is the likely diagnosis? What is the likely diagnosis in a patient with hypertension that develops? What is the likely diagnosis in a patient with hypertension that develops? That develops several weeks and several weeks that develops several week severe weakness and muscle cramps after beginning a low dose diuretic, very high L. Young patient with hypertension, you use a low dose diuretic and there is severe weakness, muscle cramps. Think about primary hyperaldosteronism. Patients with primary hyperaldosteronism are prone to develop diuretic induced hypokalemia. Diuretic induced hypokalemia include metabolic alkalosis and mild hypernatremia. So these are the things you need to remember. So in a patient uh, with young patient with hypertension, you use diuretic and the patient starts severe weakness and muscle cramps. Think about primary hyperaldosteronism. Patients with primary hyperaldosteronism are prone to develop diuretic induced hypokalemia and other findings of metabolic alkalosis and mild hypernatremia. So then aldosterone adrenocortical causes of hypertension. Okay, now in primary hyperaldosteronism, what will happen? Aldo will be high, renin will be low, and primary aldosterone to renin ratio will be higher. In secondary hyperaldosteronism, renin will be high, aldo will be high, and aldo to renin would be normal. And non-aldosterone mediated, both renin and aldo will be low, and aldosterone to renin ratio will be normal. In primary hyperaldosteronism, what are the cause or clinical example? Bilateral adrenal hyperplasia and adrenal adenoma, bilateral adrenal hyperplasia and adrenal adenoma, and secondary hyperaldosteronism, secondary hyperaldosteronism, renovascular hypertension, malignant hypertension, and renin secreting tumor. Renovascular hypertension, malignant hypertension, and renin secreting tumor, and non-aldosterone mediated. It may be Cushing syndrome. It may be Cushing syndrome. It may be exogenous mineralocorticoid like fludrocortisone and deoxycorticosterone excess. So Cushing, exogenous mineralocorticoid like fludrocortisone and deoxycorticosterone excess. In hypertension and hypokalemia, what we will do? Plasma aldo to renin ratio. If plasma aldo to renin ratio is high, it is primary hyperaldosteronism. Sorry. If we will do plasma aldo to renin ratio, if it is normal, evaluate for another cause. If it is elevated, do adrenal suppression test. If it is negative, go for evaluate for other causes. If it is positive, go for adrenal imaging. If normal and normal city and age less than 40 without or age more than 40 with abnormal city, normal city or age more than 40 with abnormal city, do adrenal venous sampling. In adrenal venous sampling, if it is unilateral adenoma or hyperplasia, consider surgery. If it is bilateral adrenal hyperplasia, medical therapy. Unilateral surgery, bilateral adrenal hyperplasia, go for medical therapy. And if it is adrenal imaging, discrete unilateral adenoma, age less than 40, consider surgery. So when the surgery should do or when the surgery should not do, there is a flow here. Like after adrenal suppression test, if it is positive, you will do adrenal imaging like CT scan of the adrenal gland, and if a CT scan is normal CT and age more than 40 with abnormal CT, go for adrenal venous sampling. If it is unilateral adenoma or hyperplasia, then consider surgery. If it is bilateral adrenal hyperplasia, then go for medical therapy. In adrenal imaging, if it is discrete unilateral adenoma, age less than 40, consider for surgery. Adrenal suppression testing usually involves salt loading and documenting inability to suppress serum aldosterone. Adrenal vein sampling, aldosterone to renin ratio to be 4 times higher in unilateral adenoma on the site of the tumor. No difference between two sites in patients with difference between two sites in patients with bilateral. So that's all about hypertension and hypokalemia. This is the way you can diagnose a patient with hypertension with hypokalemia. Now Cushing syndrome. In Cushing syndrome, we know that Cushing like central obesity. There may be skin atrophy, stria. There may be hypertension. There may be glucose intolerance, skin hyperpigmentation due to ACTH excess, depression, anxiety. What are the tests we can do for diagnosis? 24-hour urinary cortisol, late night salivary cortisol, and low dose dexamethasone suppression test versus morning cortisol level check in adrenal insufficiency, hyperandrogenism. Hirsutism can be seen in Cushing syndrome. Hirsutism can be seen in Cushing syndrome due to ACTH dependent adrenal antigen, ACTH dependent adrenal antigen production or co-secretion of cortisol and testosterone by adrenal adenoma. So hyperandrogenism, adrenal insufficiency. Adrenal insufficiency, this is a very master topic where you have to be a master. Okay, what is the likely diagnosis in patients with TB who presents with TB patient presents with hyponatremia, hyperkalemia, and eosinophilia? TB patients present with hyponatremia, and eosinophilia. It is primary adrenal insufficiency. Primary adrenal insufficiency, autoimmune adrenalitis is the number one cause. Infection and metastatic infiltration. There were fatigue, weakness, anorexia, weight loss, salt craving. This one is very important. Salt craving, postural hypertension, hyperpigmentation, and adrenal uh, acute adrenal crisis. In acute adrenal crisis, lab is there will be hyponatremia, hyperkalemia, and eosinophilia. Hyponatremia, hyperkalemia, and eosinophilia. There is low morning cortisol and high ACTH, low morning cortisol, high ACTH, and treatment is glucocorticoid, hydrocortisone, prednisolone, and mineralocorticoid like fludrocortisone. Peripheral eosinophilia is non-specific finding, sometimes seen with adrenal insufficiency as cortisol normally facilitates eosinophil migration from the bloodstream into the tissue. Cortisol normally facilitates eosinophil migration from bloodstream into the tissue. Primary adrenal insufficiency is associated with increased level of ADH. Primary adrenal insufficiency is associated with increased level of ADH. In response to volume depletion, and increased corticotropin releasing hormone leads to dilutional hyponatremia. In women with adrenal insufficiency, features of hypogonadism, loss of libido, decreased pubic hair can be seen. Decreased pubic hair can be seen due to decreased adrenal androgen production. However, men with adrenal insufficiency do not develop, as androgens are primarily produced in testes. However, men with adrenal insufficiency do not develop these findings, like loss of libido, decreased pubic hair. These are for female, not for male, because they androgens are primarily produced in the testes. But in case of female, loss of libido, decreased pubic hair can be seen due to decreased adrenal androgen production. What are the anesthetics should be given in patients with adrenal insufficiency? If patient with adrenal insufficiency, especially elderly and critically ill patient, etomidate is given. Mm. What anesthetic is associated with adrenal insufficiency, especially etomidate, due to inhibition of the alpha 11 beta due to inhibition of the 11 beta hydroxylase. What are the symptoms and signs of adrenal insufficiency? If there is adrenal insufficiency, you give 250 microgram cosintropin stimulation test. 250 microgram cosintropin stimulation test with cortisol and ACTH level. 250 microgram cosintropin stimulation test with cortisol and ACTH. If it is intermediate, further testing to assess pituitary function. Further testing to assess pituitary function. If cortisol is low, ACTH is high. If cortisol low, ACTH is high, it is primary adrenal insufficiency. If both are low, like cortisol is low, ACTH is also low, then it is secondary or tertiary minimal or suboptimal cortisol response to cosintropin. If it is normal response, cortisol level more than 20. If it is normal response, cortisol level more than 20. 30 to 60 microgram after cosintropin. Normal response 30 to 60 minutes after cosintropin. Usually unlikely to be adrenal insufficiency, investigate for another cause. So if low cortisol is primary adrenal insufficiency, low cortisol, normal ACTH. If low cortisol and low ACTH, then it is secondary or tertiary adrenal insufficiency. What is the most specific adrenal function? What is the most specific adrenal function? Most specific adrenal function is cosintropin or ACTH stimulation test. Cosintropin is a synthetic of ACTH. Cosintropin a synthetic of ACTH analog. Because the ACTH assay can take several days, an ACTH stimulation test, cosintropin test, is usually performed concurrently to rapidly confirm the test. Infusion of 250 microgram bolus of cosintropin normally triggers a rapid increase in serum cortisol. In contrast, patients with primary adrenal insufficiency will not have significant rise. In addition, most patients with central adrenal insufficiency have a response blunted response due to adrenal atrophy from chronically low ACTH. chronically low ACTH. If results are indeterminate, pituitary function testing can be considered. So you give 250, what we will do? The most important function is ACTH stimulation test, or co-syntropin is a synthetic analog of the ACTH. If we give co-syntropin, it will normally increase the production of the cortisol. In primary adrenal insufficiency, after you giving co-syntropin ACTH, there is not significant rise of the cortisol in primary adrenal insufficiency. In addition, most patients with central adrenal insufficiency have a blunted minimal response to adrenal atrophy from chronically low ACTH. Okay, in acute adrenal insufficiency or adrenal crisis, it may be due to adrenal hemorrhage or illness or surgery. In patients with chronic adrenal, and there may be pituitary apoplexy. Clinical feature: hypertension, shock, nausea, vomiting, abdominal pain, fever, and generalized weakness. Treatment is hydrocortisone or dexamethasone, rapid IV volume repletion. In patients with underlying chronic adrenal insufficiency, acute stressor can trigger adrenal crisis, which represents hypoglycemia and severe hypotension, often refractory to initial volume depletion. A standard uh, a standard a standard stress dose steroid regimen for septic shock is 200 milligram per day of IV hydrocortisone. So a standard stress dose steroid stress dose steroid regimen for septic shock is 200 milligram per day of IV hydrocortisone. Okay, finally, I'm ending this video with my intro where we'll hear the murmur. Can you tell me the name? Okay, it is MR. Hope you enjoyed my video.